Hi, good afternoon everybody. I am so excited to be back with you again for another live webinar. This topic we're discussing today is probably one of the most important topics in the whole field of infertility. I don't know how many of you realize that more than a third of women that go through fertility treatment in general, especially if it's specialized treatment like IVF, have got endometriosis. So this is an enormous topic, and the implications are enormous. In my opinion, it's often one of the most misunderstood and unfortunately mistreated problems in the fertility arena. We're going to delve into it today big time. And I'm very happy to tell you that I've left you guys with 3 articles that I've written. The most important one is one that I just finished 10 minutes before this webinar began. And I handed it over to Josh. He was able to get it on. It's a very important article that I wrote about taking a completely different look at how we deal with endometriosis. If you read that first article, then the articles that follow will spin off it, and you'll have a very good understanding of this whole issue, probably more than most. So I'm urging you to read that first article that I wrote on the revolution of endometriosis and why we need to rethink completely how we deal with the problem to help people have babies and avoid them spinning their wheels. Please read that article first. Now, the 3 articles that are on there you can simply get by clicking on my bio. It doesn't cost you anything. There's no contingencies. There's no conditions. The articles will come back to you immediately by email. I urge you to read them, especially number 1 first. Read them in the order that they're there, and I think you're going to have a lot greater understanding. Now, I'm not going to give you my first swan song about this whole situation. I'm going to wait till there are more people on, so we're going to take a couple of questions first. Random questions probably chosen because they're the first ones that appear. And last week we had almost 10,000 people attend this webinar. I have a suspicion today is going to be as big, if not bigger, because it is a topic that is so important, so enormous, and so misunderstood. So here we go. This is Josh Bell, who is my right and left hand, who does all of my videography for me and does a great job. He's going to field your questions, present them to me, and I'll do my best to answer all of them, and we'll spend 2 hours together. I think you'll find this to be very worthwhile.
Let's get it. Thank you, Dr. Sher. All right, so one of our questions here from 5324 says, advice for a 31-year-old, 2 recurrent miscarriages with 1 healthy, successful first pregnancy, all blood tests normal.
Okay. Again, a lot of this depends upon your age, your ovarian reserve, and how easily you got pregnant on your own. But when people have 2 or more miscarriages in a row, one of the things we must always think about, especially if it's a woman under the age of 35 years, that it is related not to the quality of her eggs and the embryo she produces on her own or through IVF, but rather due to an implantation problem. We're going to talk about this over and over. I like this analogy. It's a seed-soil relationship. The seed is the embryo that you're planting in the soil to get a plant to grow, which is the baby. And you've got to plant a good seed and plant it in a receptive soil. You can't put a good seed in a bad soil or a bad seed in a good soil. Most cases when women miscarry sporadically and spontaneously, it is because there's something wrong with the seed, the embryo, and it's usually because the embryo is chromosomally abnormal. Something I know quite a bit about because Dr. Tortorello and I introduced PGTA into the field of IVF clinically back 20 years ago, and it's been a major game changer. It doesn't make the embryos any better, but it tells you which ones are good. And if you put a good one into a good soil, 60% of the time you should have a success. But if you put a bad one into a good soil, it won't take, or if you put a good one into a bad soil. Now, in this case, where you've lost 2 pregnancies in a row, especially if you're younger, one of the common causes of it is a problem with the soil. And that's where it can be related to the thickness of the lining. So there's got to be enough soil in the bladder box for the roots of the embryos to attach, or it's got to be the regularity of the bladder box inside. The uterus has to be completely smooth, something we can only pick up if we do a saline ultrasound or do hysteroscopy or an MRI, but that's an overkill. And we can tell if the inside is smooth. If it's not, it'll irritate the lining and reject the embryo. And the third is immunologic. This is something that is controversial. Not everybody's going to agree with me. I'm one of the pioneers in the field of clinical reproductive immunology, going back to the 90s. And I want you to know, I have absolutely no doubt we've helped thousands of women have babies by recognizing the problem which so many doctors don't even want to recognize because it's so complex. The area of immunology is far greater than the whole field of IVF. And most doctors will turn around to you and say, we don't believe it. And guess, if you get that said to you, you must be suspicious and ask the simple question, okay, doc, if you don't believe it, I accept it, but tell me what it is you don't believe. And then you will see, because you also get access to getting 2 books free of charge by clicking on the bio. These 2 books here that I've written with Dr. Tortoriello on the immunology and IVF arenas. They come to you free by immediate return, just clicking on that link with no conditions. And you can read them selectively, and you will see more in this thin book here. Over here, a lot of it is on the immunologic aspects of failure to conceive or miscarriages. You'll read more about it there. We're not going to go into a detail here. We spent last week going over this topic in some detail. And if you're really interested in knowing what it's all about, I suggest you go to YouTube and you pick up the entire session of 2 hours that we did last week, and you'll get all this information there as well. As well, if you want to get an article I wrote on recurrent loss, pregnancy loss, all you need to do is contact Patty, my office manager, and there's information on how to do that on my bio, and she will send you the article that I wrote on that topic as well.
Perfect. If you guys are just now scrolling in and coming across Dr. Sher, we're answering questions on endometriosis and specifically IVF questions. We're going to answer a few questions here before we get into a little seminar that Dr. Sher will go into depth about endometriosis shortly here. We're going to answer Christina on TikTok. She says, I was diagnosed with stage 1 silent endometriosis. Could this have caused recurrent 5-week pregnancy loss?
Not likely, but it can. Most people that have problems in getting pregnant, that is being caused by endometriosis, if it is due to an immunologic factor, and I'm going to go into this in detail in a few moments, and if you read that first article, that you can pick up the first and most important one on my bio, it'll explain that to you too. Yes, it can be, but it's not likely to be not likely a common cause of repeated miscarriage.
We're going to answer Rita. She says, can transfers work with endo without Lupron?
Can transfers work without Lupron? Of course they can. But I don't know why you need the Lupron. And that I'm going to be discussing also in about 10 minutes. When Josh gives me the word to start launching, I will then discuss the overview first, and we'll discuss that there as well.
Aaliyah says, do you advise MRI of the pelvic before getting a hysteroscopy after 2 embryos failed?
No, you don't need an MRI. You can do a simple saline sonogram, which is the easy way, a little tea-break procedure that your doctor can do in his office or her office, or you can do a hysteroscopy. But you don't need an MRI. Does an MRI give you the same answer? Yes. If the radiologist understands what it's all about and gives you a proper report, the answer is yes, you can get the same information. But it's a bit of an overkill. You don't need more than a saline sonogram and perhaps doing hysteroscopy.
Yvette on TikTok says, should you get prescribed medication for endometriosis pain?
Depends how severe the pain is. And the answer is yes. Pain can be severe. The types of pain you get is you have pain with your menstruation, which is very, very severe. And typically with endometriosis, the pain begins as the periods begin and gets worse as the periods go on. Whereas when you have pain being caused by other chronic pelvic conditions like pelvic adhesions and pelvic inflammation, the pain starts a few days before the periods. And as soon as the period starts, the pain goes away or gets better. That's typical of the other causes. So that's one type of pain. The other pain you can get is pain with intercourse. When you have deep penetration and it bumps up against these deposits, it can cause acute pain. That commonly occurs just before the periods. That pain is harder to treat and often requires surgery to get rid of the lesions so you don't have the pain. And then the other cause of pain is when you ovulate. Women with endometriosis often get ovulation pain. Very commonly it occurs in one or other ovary. It doesn't usually go from one ovary to the other, it's in one or other ovary. When we get a woman with a triad of those things, heavy periods, prolonged bleeding, pain with intercourse, pain with ovulation, then we know that we are likely to be dealing with endometriosis. And we've got to dig deeper. And to dig deeper, today you don't need surgery, a laparoscopy to diagnose it. There's a simple metabolic test, molecular test, that you can do. It's called a receptiva test or a BCL6 test. It can be done in the doctor's office. You get the result the next day, and if it's positive, it's 90% certain you've got endometriosis. And you will get that test positive even before the endometriosis can be seen at surgery, and you should know, and you'll learn about this later, even if you can't see it, if you've got it developing, you're going to have problems that are associated with fertility in endometriosis.
We're going to answer Fran Fines, but before we do that really quick, if anybody's scrolling through for the first time and just coming across Dr. Sher, we are answering questions on endometriosis, and we'll be giving a seminar today about endo and all the solutions, the causes, the common roots to them, and everything else. If you're looking to get more information, more than just what Dr. Sher is answering today, go check out the link in bio. There's multiple articles, one of which Dr. Sher just finished earlier before we went live. 3 articles exclusive to only you guys, anybody who's in this live stream right now. They are specifically about endometriosis, and they will not be there after the end of this live stream. So now's your only chance to go grab them, completely free. They send right to you instantly. And if you fill out a questionnaire, you can have a one-on-one conversation with Dr. Sher. It just takes 4 minutes of your time. All of that's in the link in bio. Go check that out. We're going to answer Fran Fines on TikTok here. She says, endometriosis was removed. Can I conceive naturally? Only have one tube.
So one thing I'm going to tell you about in a few moments. He's going to give me the nod in a few minutes. And the answer is, endometriosis is forever. It's a gift that keeps on giving. Once you've got it until you go through menopause. And it continues. If you treat it, and you said it was treated surgically and removed, you can't get rid of it. For every one lesion you remove, there are another 20 or 30 coming up. And they're causing problems even before you can see them. So unfortunately, the answer is surgery is not a cure for endometriosis. It may alleviate pain, suffering, and deal with complications that can occur from endometriosis. But it is not a cure for the fertility problems relating to endometriosis. And we'll discuss this in a few moments.
We're going to answer one more question, and then we'll go right into a full seminar here. I want to answer, it's Liz on TikTok. They said, can an IUD cause endo or endometriosis or endometritis?
An IUD cannot cause endometriosis, but if inflammation occurs and goes up along the wick of the IUD into the uterus, it can cause inflammation in the uterus. But usually when you take the IUD out and you start menstruating, you shed the lining every month, you get rid of the infection, and contrary to what everybody tells you, that you should culture this uterus to see if you've got endometritis and treat it, you don't have chronic endometritis unless you're in a very, very rare group of people. And we're seeing more and more of it as we get more and more people immigrating into this country from third world environments, called uterine tuberculosis. Interestingly, in India and other parts of Asia, it's one of the commonest causes of infertility, and it causes a severe form of endometritis that destroys the uterine lining and even the ovaries. So endometritis that is chronic is a rare bird, yet everybody's testing for it and doing Emma and Alice testing, cultures and treatments. I don't believe it works, because every month when you menstruate, you shed your lining. The menstrual blood that flows from the uterus has got antibacterial properties, and usually the infection doesn't take hold in the uterus unless it's the rare form I've just told you.
All right, you're good to start whenever you'd like.
Okay. We need to rethink the whole area of endometriosis. This is going to take me 10 or 15 minutes, and for those of you that want to revisit it, it'll be on YouTube after we've done this whole session. And if you read the first article I provided to you, by far it's the most important. If you read that and then follow up with the other two, you'll get a support of what I've told you. And then go and watch this again on YouTube if you like. Endometriosis is a condition where the lining of the uterus grows outside the uterus, usually in the pelvic organs and around them. But in some rare cases it can get to distal areas. Gets to the lung, the brain, to the belly button, to other organs. But that's rare. Mostly it's confined to the pelvic area of the woman. And what it is are deposits of the uterine lining called the endometrium, which reach the outside of the tubes in the uterus and start to grow on the surface of the uterine cavity. Now what you should know is all women who menstruate at times, if they've got at least one open tube, will menstruate backwards through the tubes as well. And what goes out through the end of the tubes spills out through the showerhead-like fimbrial ends of the tube over the pelvic organs. Now all the organs of the pelvis, bowel, uterus, ovaries, are covered by a saran wrap like porous membrane that covers all the organs. Because it's porous, secretions come through, and the purpose of those secretions is to allow all the organs to slide over one another smoothly without adhering like inverted Scotch tape, because that causes adhesions and problems, pain and infertility. So this secretions are there for that reason. Now, because when women menstruate, they also menstruate backwards through the tubes. Some of the blood that comes out through the tubes contains live cells of the endometrial lining. And these cells love to grow on this porous membrane known as the peritoneum. And they grow all over in the pelvis. You can't see them at first. They are translucent, but they grow there. They multiply under the effect of estrogen produced by the ovaries, by the follicles in the first 2 weeks of the cycle. And they multiply the cells on the surface of the peritoneum in little islets all over the pelvic surface. And what happens is they grow and grow, and then the woman ovulates. And then she produces another hormone called progesterone. That progesterone sends a signal to the woman's immune system, the janitorial system in her body, to send down immune cells called macrophages, monocytes, and others. They journey through those pores in the peritoneal membrane. They get into the pelvis, and those of you who are old enough to remember, there was a game called Pac-Man. There are little Pac-Men that go and gobble up all these deposits, clean the room out, and then they spit it out, and then the next period begins. You've got a clean room and it all starts over again. That happens in all women who've got open tubes. Not every month, but very often. Now, in some women, interestingly, I can describe those of you with endometriosis. I'll be right 80% of the time. Usually it's women that are take charge individuals, type A personalities, women that are driven, are the credit to their gender when it comes to profession. These are the type of women that go read up more about their condition than the doctor in Google and everywhere else. They come to the doctor with chapter and verse. These type of emotionally intense women tend to have an immune system that is slightly dumbed down. And I believe, and others also believe, not everybody, that this depression in the immune response means that these little deposits that are cleared every month when the janitorial cells arrive, it doesn't occur that efficiently. And now, every month after year, these deposits build up. And these deposits now will bleed into their substance, causing the pain you get with your periods, causing the pain you get with ovulation, causing the pain you get with intercourse. These deposits now have blood in them. And now the menstruation stops. And the blood in these deposits absorbs, leaving behind an iron pigment, because the red stuff in blood called hemoglobin is mainly an iron compound. And so when it absorbs, it leaves behind the pigment. And when you then do a laparoscopy or operate on the woman, you look inside, what you see are like gunpowder burns, dark spots all over the show, or what often is described as small pigeon eyes looking at you. All this is the hemosiderin deposits showing you where these lesions formed. Very often doctors look at this and they say, well, you never had it 5 years ago when I looked in your belly. Now you've got it. You've just developed endometriosis. Wrong. You've had the endometriosis potential all your life. In fact, there's some people who believe those deposits are there because as your uterus develops from a system embryologically known as the Mullerian system, some of these cells that form the lining of the uterus are left in certain areas outside the uterus, and then for genetic reasons or inflammatory reasons, they start to grow and form endometriosis. That's a theory that says one of the causes may be related to this embryological theory. But the most likely explanation is what I described. This reversed menstruation that occurs in all women, and in certain women that are more predisposed because of their disposition, they're the ones that end up with the lesions. Well, then, of course, these lesions can become confluent, they can merge, and now the surface of the peritoneum is no longer sliding smoothly over other surfaces. It starts to stick, and you get adhesions. And if you realize that when a woman menstruates, if blood is issuing out of the ends of the tubes that hang over the ovaries, the first organ to be attacked is the ovary. And so you get deposits starting in the ovary, and when they merge, now the woman menstruates into them, and blood collects, which is menstrual blood, that expands in some women, forming cysts that, because they contain menstrual blood which decomposes and starts to look like melted chocolate, they call them chocolate cysts or endometriomas, and they form in the ovaries. They can burst, spread at other parts of the pelvis. Sometimes the stuff can get into the blood system or into lymphatics and spread beyond the pelvis as well. But the bottom line is that these deposits that you get of endometriosis have occurred because, in most cases, of this reversed menstruation. Now, the commonest cause of reduced fertility, and let me make it clear, women with endometriosis usually are not sterile. They still can get pregnant on their own. Sometimes they get fertility drugs, and they get pregnant with the fertility drugs, but I'm going to make it clear to you in a moment, and I want you to absorb this. If women get pregnant on fertility drugs or on their own, and they've got endometriosis, no matter how mild it is, first stage endometriosis, they're getting pregnant in spite of the treatment they received. Not unless it's IVF, in spite of the treatment. Because these deposits in the pelvis release toxins, chemokines, cytokines, inflammatory substances into the pelvic secretions. And now as the egg leaves the ovary when you ovulate, from the ovary it's got to swim over through these secretions to get to the tube and go down the tube through proper movement of the tube like an earthworm, meet the sperm along the way and be fertilized. Problem is that when the egg gets into these secretions, it's like you diving into a river full of alligators or a river full of piranha fish. You may get to the other bank, but the likelihood you'll get to the bank in a condition to be able to get up and make a journey into the interior is remote. The eggs have got an envelopment around them like a chicken egg called the zona pellucida. This envelopment has little receptors like keyholes in it to which the sperm attaches in order to, one of them to enter into the egg. These keyholes get blocked, become obstructive to the sperm because of the toxic effects of the pelvic secretions. There is a toxic peritoneal effect caused by endometriosis even before you can see it. And women, before you can see the endometriosis, I already explained, it can be invisible, translucent. Even those women have got increased toxins in the pelvis, and their ability to get pregnant is reduced, which is why many of these women, if they come to you before they've ever been diagnosed, they come to you with a diagnosis of unexplained infertility. They come back 5 years later, you do a laparoscopy, you look inside, and you see they've got endometriosis that are visible as these pigeon eyes or gunpowder burns. So I'm trying to explain that endometriosis is more than just an anatomical disease. It's an entire process that's going on. You can't just treat it as if it were a surgical problem that you clear up and clean up and it's gone. Because the toxic pelvic environment is persistent. So now please listen very carefully. If you've got a toxic environment in the pelvis, and I give you fertility drugs, and even if I do a procedure that I introduced into the field of medicine called IUI, intrauterine insemination, your chance of getting pregnant is no greater than nothing at all. In fact, it's, in my way of thinking, a relative contraindication to IUI, because the egg has got to leave the ovary, even if there are more than one of them, swim across this toxic pelvic environment to get into the tube and be fertilized in a condition that it can be fertilized. And as I've told you, it can't escape this toxic impact. So if you do IUI to make a woman release more eggs, they still take the same circuitous route through the toxic environment, which is why fertility drugs, IUI, or no treatment, you could get pregnant. You could, and some women do. And the sad thing is that if you do, the doctor says, you know what, we used Clomid on you. We used letrozole on you. We did IUI. You got pregnant. All you got to do is do it again. You'll get pregnant again. The same problem that existed before, where you got pregnant by luck, in spite of the treatment, not due to it, exists. That's why doing IUIs, doing surgery to get rid of lesions that you can see in the knowledge that for every one you remove, there are another 20 or more coming up, causing this toxic environment, does not improve your chances of getting pregnant in the long term. The only thing that will improve your chances, and I'm not saying everybody with endometriosis needs it, is IVF. Because here you go in and you remove the eggs from the ovaries before they're released into this toxic environment. And then you fertilize them in the laboratory and you put the embryo into the uterus. Now you've bypassed this hostile environment and she can get pregnant as if it wasn't a problem, with one important caveat. If she's got endometriosis, and listen again, regardless of severity, and again, you're going to get a lot of people disagreeing with me, and I'm happy, let them disagree. I'm telling you this, and if you read that first article, you'll understand it even better. A third of women who've got endometriosis, and I was the first to show this back in the 90s, will have an immunologic barrier to the embryo attaching. Remember I told you earlier, we're talking about a seed-soil relationship. The seed is the embryo you're planting. The soil is the uterine lining. You can't put a good seed in a bad soil. And if you've got an immune barrier to fertility in the uterus, where you've got certain cells called natural killer cells that all women have got, must have, because they play a vital role in regulating the normal growth of the roots of the embryo into the wall of the uterus. And without them, we wouldn't exist as a species. But they've got to function normally, and they function by releasing growth factors we call cytokines. There are many types, but the two that are important here is Th1 and Th2 cytokines. The type 2 or Th2 attract the roots into the wall of the uterus to make it form the lifeline that will become the placenta that will feed the baby. That's type 2 cytokines. But if you didn't have an opposing force by releasing type 1 cytokines, which trim down and prune down the cells, kill them off through a process we call apoptosis. If they're activated, you've got to bring the type 1 and 2 cytokines into balance. Now, I was one of the people that introduced clinical reproductive immunology into the IVF arena in the 90s. Today, we know a lot more on how to regulate these natural killer cells. We used to use substances called IVIG, which is a blood product which we infused, which brought them into apposition and into balance, the cytokines, and women could get pregnant. Today, we know we don't need it because IVIG is extremely expensive, causes a lot of side effects, and in some cases even reported fatalities. But it works extremely well if you know how to use it. It works effectively. It works very well indeed, but it's highly expensive. Often it can cost about almost as much as half of an IVF cycle or more. So using IVIG is no longer in vogue. Instead, we've come up with a substance called intralipid, which works just as well as IVIG. It is 30 times less expensive. It is synthetic, so it's not a blood product. It's not going to perpetuate AIDS or hepatitis. And it is equally effective, highly expensive, with very, very minor, if any, side effects. If you use intralipid or IVIG, you've got to give it in combination with a steroid like prednisone or dexamethasone for a short period of time. And if you do that, you bring the type 1 and 2 cytokines into balance, and now when you put the embryo in the uterus, it won't be attacked by the cytokines, and you'll end up with a chance of success as if you never had the problem. So in women who've got endometriosis, it's extremely important to find out. We know automatically that the only way to improve their chances of having a baby is IVF. If they're young enough, they're under 35, and their ovarian reserve is normal with a high AMH, they can try on their own for a while, see if they can get pregnant. But if they do, it's a fluke. It's good luck. It's not going to keep happening over and over with the same treatment for all the reasons I gave you. Only thing that will improve your chances is IVF. And if you do IVF, you've got to be sure that you're putting the embryo into an environment that's not going to expel it. And what will expel it is if you've got an immunologic problem, or if the lining of the uterus is too thin to allow the roots of the embryo to attach properly, or if you've got little growths inside the uterus caused by scarring or little polyps that look like mushrooms that grow into the cavity that irritate the lining, it will prevent implantation. If you put a good embryo that you've tested and you know it's normal chromosomally by doing PGTA, as I told you, a procedure Dr. Tortoriello and I engineered starting more than 20 years ago, it is very important because it helps us tell which embryo has got all 46 chromosomes. Therefore, it's the one most likely to make a baby if it finds itself in a receptive uterus. So if you put a good embryo in the uterus, it'll make a baby 60% of the time. The key is to know which ones are good. And the older you get, the lower the chance that any embryo will be good, because the quality of the embryo stems from the egg. So therefore, you've got to know that as you get older, there's a wear and tear effect on your eggs. They become degenerate, and you end up with embryos that are more likely to be chromosomally abnormal. So the PGTA tells you which ones are good. So you know which seeds to plant. Then you've got to plant it in a uterus that's receptive, which means you've got to inspect the inside of the uterus by doing a saline sonogram or hysteroscopy. You've got to make sure there's no immunologic problem, regardless of how severe the endometriosis is, so you can treat it and take it out of the way. And you don't need surgery to deal with any endometriomas. In this day and age, we have developed a method. 15 years ago, I was the first to publish, and it came out, called sclerotherapy. We can inject something into the endometrioma that causes it to absorb without surgery. Yet so many women are still having laparoscopies to remove these endometriomas. Yes, they can't be there, but you don't need surgery to get rid of them if you can do it through an outpatient procedure, inexpensive, not risky, safe. And this process is not available everywhere. Most doctors don't ascribe to it. But I'm telling you now, sclerotherapy is a game changer, because if you've got that cyst with this chocolate fluid in the ovary, it'll cause the ovary to overproduce testosterone. And if your ovary overproduces testosterone, by the way, you have to have some testosterone or you won't make follicles and eggs develop. But if you overproduce it, it'll compromise follicle growth, compromise egg development, and you'll have a problem in the ovary that has the endometrioma. The other one's going to be okay, so you've got to remove it. The way traditionally it's removed, doctors go in and they remove the endometrioma, or they laser away the wall to kill all of the lining cells that bleed, and then it absorbs. But the problem is you can damage the ovarian tissue. You can destroy eggs and make things more compromised and complicated. You don't need it any longer. All you do is put the woman under conscious sedation, drain out the fluid in the endometrioma, inject 95% alcohol into the cyst, allow it to stay there for a while, remove the needle, and the woman goes home. 6 weeks later, it's gone in 90% of cases, or 85% of cases. And if it's not gone, what you're left with is a clear cyst. All you go in there with a needle and drain it, and it doesn't come back in almost all cases. So sclerotherapy is a game changer. There are not many, more than a handful of places in the world that know how to do it. And we have a clinic in SFS in New York, run by my partner, Dr. Ravi Kumar, Dr. Sitara Ravi Kumar. I have helped her develop that clinic. We can do sclerotherapy for you no matter where you come from. All you commit to is one day to be with us, to get it done. You go home, it's gone. 8 weeks later, we can do IVF without having to do surgery. So I want you to understand, treating endometriosis must take all these factors into consideration. And these articles that I've written for you, especially the first one, puts it all in perspective. Also, you often hear doctors tell you, endometriosis contains endometrial tissue, and the way to treat it is to use Lupron, Buserelin, Superfact, Decapeptyl, which are all known as agonists, because they stop the ovary from producing estrogen. And in the process, these lesions will shrink, but only temporarily. The moment you go back and you start taking away that treatment, within a few weeks you're back to where you started again, and it didn't help you. But worse still, by giving depot injections once a month of these agonists to suppress the endometriomas, to suppress the endometriosis, it won't work for you, because it sends the ovary into a menopause, and so it stops producing estrogen as it should. And if your ovaries are not producing estrogen, then the uterine lining, which needs to be signaled by estrogen produced by the ovaries to be able to respond to estrogen, dry up, and you can't produce a good lining. And if the lining's too thin, under 8 millimeters, at the time of ovulation or trigger, you're definitely not going to be able to implant an embryo. So I don't believe there's a place, and it's my opinion, and I'm saying it again, others will differ, and I respect their right to differ. I don't think there's a place for agonists any longer either. Long-term injections of Lupron or Decapeptyl, I don't believe it has a role. I think what you need to do is you need to stimulate the woman, get the eggs, freeze the embryos after doing PGTA, and then make sure the uterus is receptive when you put the embryos in. I don't think using Lupron is the way to go. So that gives you a little bit of a background. Hopefully this will form the basis of any further questions that come up. And again, read article number 1 in the bio. All you have to do is go to the bio, click on the link which gives you those 3 articles and the 2 books completely free. It gets to you and you can read it selectively. The one you must read to start with is the first article, the one I just completed just before we did this webinar. Also, if any of you feel you would like to talk to me, all you got to do is click on the link where it says that you can get a questionnaire. It'll come up immediately. It's only a 4-minute questionnaire. You fill in that questionnaire, that will get back to us. We'll then reach out to you and set up a time for you and I to talk. But you've got to take that process of going in there, getting the information to read, and then going to the questionnaire if you want to talk to me. And I'm more than happy to be there to discuss it with you.
Perfect. Thank you for that presentation. That was awesome. If you guys are commenting questions, we're about to start answering them. If you don't get your comment answered today by Dr. Sher, please go check out the link in bio. You're getting 5 assets today that we typically don't give out. So you guys definitely go check that out. There are 3 articles. They're exclusive to today and its topic about endo, and they will not be there at the end of this live stream. We get rid of the article every single time, so you can only get access to the articles on Saturday. They're custom-made articles. Dr. Sher writes it specifically about the topic that we're going over for the day. Thank you all for being here so far. We're going to go start answering questions, and I'm going to answer Paige here on TikTok first. She says, can diet make a big difference in endometriosis to make it go down?
Unfortunately, it's a simple answer. The answer is no.
If endometriosis is found and cleaned up, how long until it can start to grow back again? Sarah Lynn.
It's growing back already, even while they're cleaning it up. For every lesion they clean up, there are another 20 or 30 coming up. That's why you can never get rid of it. It's with you for your entire reproductive life. And again, I want to emphasize, you cannot get rid of endometriosis, which is why you've got to deal with the broader underpinnings, which have to do with implantation, which have to do with the quality of the eggs, which have to do with ovulation. All of the things that I spent some time discussing a few minutes ago. Please go over that carefully, and if you've forgotten, go to the first article on the bio, which explains, it puts it all in perspective for you.
Perfect. All right, we're going to answer Lisa on TikTok. She says, I had endo stage 4 on left ovary. I had surgery, went from AMH, sorry, let me open this message back up, to 0.3. Is fertility still possible?
Yes, 0.3 is bad, but it's not terrible. And that you're probably an example of what I was talking about in my discussion. If you go in and you treat endometriosis by surgery, you're often removing a lot of the eggs in the ovary as well. So you're left with fewer eggs, and that's what brings your AMH down. Also, endometriosis itself, if it's disseminated in the ovary, can destroy the follicles, yes. But the common cause is when there's an associated endometrioma that was treated laparoscopically, you don't need it any longer. We can do sclerotherapy for you and get rid of the problem without surgery and not damage the ovary and destroy your eggs.
I'm going to reply to Davin on TikTok here. They said, can you talk about how effective tranexamic acid is for...
Heavy bleeding.
Heavy bleeding, yes.
Yeah.
In treating heavy bleeding.
Okay. Tranexamic acid is an antifibrinolytic agent that you take orally. And when you bleed excessively, whatever the mechanism in the ovary, there's a process called fibrinolysis. And that happens in the body all the time. If you get a blood clot, the clot clots because of thrombosis. And then the clot itself is dissolved through fibrinolysis. And tranexamic acid blocks the dissolving of that clot, and therefore it prevents you from bleeding heavily. And so the thrombosis blocks the blood vessels and you don't bleed. It will work to reduce the bleeding, depending on the cause of the bleeding. Most cases it'll work, but it's a heavy drug to take. And one of the problems in taking a antifibrinolytic agent like tranexamic acid or epsilon aminocaproic acid, which is a derivative, the two are derivatives of one another, is that it can cause your blood to clot, and you can get blood clots spreading in your body, and you can end up with clotting intravascularly, and that can even spread to the lungs. Tranexamic acid is good, but it's got to be very selectively used when there's no other alternative to fix the problem.
All right. If we don't get to your question today, we will answer you in DMs, or if you want to go to the link in bio and have a one-on-one consultation with Dr. Sher, because you just love how much information he's giving out here. He will have a full one-on-one conversation with you. It takes a 4 minutes of your time to fill out a little survey, and he'll get right back to you. We're gonna answer Lana Donna on TikTok here. She says, "What's your opinion on using it's a JOURNAVX after endometriosis excision surgery as part of pain?"
I don't think there's any problem using painkillers, but I'm not familiar with that particular drug.
JOURNAVX is what it's.
How do you spell that?
JOURNAVX, all one word.
Let me quickly look. Go and ask the question. I will look it up over here and see if I can find out what it is.
Alrighty, let's go to a different question while he looks that up for right now. Go ahead and comment your question. There's so many good questions here, guys. Thank you for commenting. My right.
JORDNA. What?
JOUR. Where'd it go? Sorry, let's scroll back up.
Jorna NA.
NA and then VX.
VX. Let's see what the hell that is. Jornavax. Okay, I'm learning something here. Let's see what it is. It's something new and I wasn't aware of it. It's a prescription meds treated patients with long-term acute pain, including post-operative pain. Okay. I don't think there's any problem using this for pain if it's that severe.
Specifically after endometriosis.
Go with the question.
All right, I have another one here from C. Bessinger. They said GLP-1 to help suppress inflammation with endometriosis before and during FET. Yay or nay?
What did they ask for?
GLP-1
Yes, you can use it.
to help suppress inflammation for endometriosis.
Yes, you can. Not that I'm sure it's going to help. But let me see. CYP3A inhibitors.
I'm going to go to another question here while she's looking at that. Is it important to do lap if trying to conceive? I had adenomyosis, sorry. Is LDN not enough?
I do not think you need to do, what did they say, surgery?
The other one was the surgery. This is a different question.
This one is?
This one is about, is it important to do lap if trying to conceive?
Well, laparoscopy is surgery.
Sorry.
And laparotomy, no, it's not. I don't think there's any indication, as I pointed out. And if you read that first article I've given you, there are ways to deal with it. There's nothing surgical you're going to do that's going to change the situation. I don't think it's going to help at all, unless the doctor's going in there to do something due to a complication of endometriosis that's affecting your health and well-being. If it's a cyst, sclerotherapy can fix it. You don't need surgery. You don't need laparoscopy to diagnose endometriosis anymore either. You can make a diagnosis with a BCL6 and using that in conjunction with your clinical presentation. So I don't think there's an indication for surgery.
I'm going to answer this comment here on TikTok. They said, what can be done with endo on sciatica nerve? Is that how you say that right? I get leg pain.
Okay. That's problematic because it causes inflammation on the sciatic nerve and, of course, shooting pains down the leg. The endometriosis on the nerve itself needs to be removed. You need a very skilled surgeon that can do that, usually a neurosurgeon who can go in and remove it. But if the pain is extremely severe and your main issue is pain, yes, that is where an agonist like Lupron or Glycerin, Superfact or Decapeptyl can shrink it and ease the pain. So that may be one of those examples I gave you of whether there's something affecting your health and well-being, not primarily directed at the infertility.
I'm going to answer Hassa on TikTok here. They said, my sister would like you to know, or like to know how to help reduce pain for endometriosis, currently on birth control.
Again, it depends what's causing the pain. Endometriosis causes pain with intercourse, pain with ovulation. It causes pain with heavy periods as well with it. These are symptoms that occur with endometriosis. Very difficult to treat. You have to treat them symptomatically with various grades of painkillers. And there's a whole group of pills you can use. Stopping you ovulating with a birth control pill is not going to remove the pain with endometriosis. Because once you menstruate, the lesions in the pelvis will then expand, become congested, and you'll have the pain. Sometimes, if the pain is the main issue, and it's not an issue of trying to get pregnant, that's where you can use long-acting agonists like Lupron, Glycerin, or Superfact. You can use it, but it's not going to help the fertility aspect of things.
We're going to answer Luis here on TikTok. They said endo and low AMH trying to conceive. Any suggestions?
Well, you've got to look at this as diminished ovarian reserve and ask the question why. Is it related to you having had severe disease of the ovaries with endometriomas that were removed surgically so that many of your egg-bearing tissue was removed? Or is it due to disseminated endometriosis destroying the ovary? Or is it independent, relating to the fact that you're older or you've got an endemic predisposition towards running out of eggs early? People are born with all the eggs they're going to ever have. They use them up progressively, and when they drop below a certain point, they have diminished reserve. So your focus has to be on, number one, is there something you've got to do to the ovaries to start with to get you ready for the treatment that is directed at trying to get you to produce good eggs in spite of diminished reserve. And here you need to listen very carefully. The most important consideration with diminished reserve is to use an individualized protocol for ovarian stimulation. One that doesn't bombard your ovaries with too much LH from your pituitary by giving you too much menopur, pergoveris, which contain a lot of LH. That'll make your ovaries overproduce testosterone and damage the follicles and the eggs in them. So in a woman with diminished reserve, you need to use a very individualized protocol for stimulation, not a recipe one size fits all. This is something that people come to me from all over the world for. I'd be very happy to talk to you about it. All you got to do is request through the bringing up the questionnaire on the bio, request a consultation with me online. And these are all online consultations, so it doesn't matter where you're located. We can talk. And if you do that, we can discuss what kind of protocol would be most appropriate for you, and that'll depend upon answers to a lot of questions that I would ask you during the consultation.
I see some people filling out the form right now. I'm getting the push notification email. Thank you so much if you're filling out the forms. We really appreciate that. Dr. Sher will reach out to you ASAP. If those of you who have been commenting for a minute and have not gotten your question answered, please go check out the link in bio. Fill out all the information there, and you can get a one-on-one conversation with Dr. Sher. Or if you're just looking to get a little bit more info on endometriosis and learning more about it, Dr. Sher has 3 exclusive articles that he's written. One of them he just finished earlier, specifically on endometriosis that he wrote. Highly recommend everyone go check those out. They're really informative. Additionally to that, he's got 2 free ebooks for everybody that is a part of today's live stream. So go check that out. Get your free ebooks. They're sent to you directly. You guys get direct access right after you fill it out. Nothing's asked of you, just some simple email information so we can send it right over to you. We're going to reply to Nydia on TikTok and answer their question. If you guys have a question on endometriosis or just an IVF question, please don't hesitate to comment it and we'll try to get to it ASAP. Nydia says, hi, yesterday I had a hysterosalpingogram.
Or
no, it's hysterosonography.
Hysterosonogram.
Okay, that word there. And I'm having bad cramps. Should I, sorry, I gotta open the messages, consult?
Well, it all depends. You shouldn't be cramping any longer from a saline sonogram yesterday. If you are, you've got to be careful that you haven't got infected in the process. Maybe you should contact your doctor and tell him you want to be checked, because if you've got inflammation from it, it could cause problems, other unrelated problems down the line. So yes, and the other thing is sometimes, even with the hysterosonogram, you can inject bacteria into the tube and cause tubal infection, which is even worse. So you need to talk to your doctor in case he wants to put you on antibiotics. The giveaway is if you're running a fever, if your pulse rate is running fast, if you've got pain in your lower abdomen, that's worse on movement. So when you move from one position to the other, it aggravates the pain. And if you've got lower backache with it, that's also a factor. So definitely get back to your doctor and ask your doctor what to do in case it's infection.
We're going to answer Katie here on TikTok. They asked, can a Mirena coil cause ovarian cyst?
No.
Simple answer there. We're going to go to another question here. What do they need to have? Let me go back up, sorry. Someone who had diaphragmatic endometriosis excised. Sorry, that's
yes.
Verification. Sorry.
What about it?
Will they need to have a C-section? That's from Victoria. Sorry.
Okay, the answer is not necessarily, but remember I told you in the beginning, endometriosis is usually localized to the pelvis, but it can spread elsewhere, to the diaphragm, to the liver, to the lungs, to the brain, to the bones. It can go anywhere. It can go to the vulva, to the vagina, to the belly button. So yes, it can spread, but that's extremely rare. Diaphragmatic endometriosis is extremely rare. But when it does occur, all it's telling you is you've got the condition, and everything I've mentioned about the fertility-related issues are there. The endometriosis, if the problem is pain, if the problem is unrelated to fertility, the treatment's completely different, because then you focus on the pain, and that's where things like using the agonist, the GRH agonist, may be helpful in causing these lesions to shrink and the pain to get better.
All right, for those who are just now scrolling past Dr. Sher, he is answering IVF questions and fertility questions, and specifically today's topic is endometriosis. We're answering all the comments here as much as we can. If we don't get to your question today, check out the link in bio. There are 3 exclusive articles on endometriosis, specifically endometriosis. There's so much knowledge in them. Dr. Sher just finished writing one of them literally like less than an hour ago. I highly recommend everyone go check those out. I see people filling out the forms right now, so thank you so much. Dr. Sher will get back to you one-on-one in person, and you guys can have your consultation anytime. If you'd like to talk to Dr. Sher one-on-one, there is a form on there you can fill out. It literally takes like 4 minutes of your time. You can fill out some basic information, and he'll reach out to you and get to you.
And online.
Online. All of this is online, accessible. You do not have to leave your home. You get free books, free articles.
And the consults online.
And the consultation, that's all featured online for you guys. Everything's through that link. Go check it out. We're going to answer Cassandra here on TikTok here. She has a question about IVF. She has having chest pain and shortness of breath. They said they are 95% positive. I have endo. Is this relatable?
It's a very rare presentation in the lungs, but of course, as I pointed out earlier, it can occur in the lungs as well. And they're going to need to be able to make a diagnosis by a biopsy or by examining the sputum to look for endometrial cells. There are lots of things that can be done, an MRI of the chest, a CT scan with contrast. These are all things that can help make the diagnosis. And of course, doing the Reproductive test is also helpful. But it all depends what your problem is. Not everybody with endometriosis is focused on fertility. They're focused on pain, quality of life. The treatment's completely different. The protective mechanisms that we implement to protect your reproductive potential when you're trying to have a baby differs completely. Things that fall away when we're treating endometriosis-related complications.
Thank you, Gigi and Cassandra, for gifting. And anyone else who's gifted, thank you so much. I did not see them earlier, but I see that there is some gifts. Thank you so much. We're going to answer Chapter and Charm on TikTok here. They said, my right ovary is attached to the right posterior uterus. What does this mean?
Means that you've got, if it's endometriosis, that the ovarian endometriosis has stuck to the peritoneal surface, the membrane that envelops the uterus, so it's stuck to the back of the uterus. That per se is not the problem. The problem is what else is going on in the ovary. Do you have a chocolate cyst, an endometrioma that needs to be dealt with? That's got to be looked at. And what is the focus of your attention? Is it trying to have a baby? In which case, as I told you, IVF is going to be needed. But the question is what you have to do to get ready to IVF to give you the best chance of success. Again, I want to mention to you, have we got a lot of people there right now?
Yeah, we've got over 100 plus people, yeah.
Okay, for all of you watching, there is no downside to getting the articles that I've written specially for you. All you got to do is go to the bio, click on those links, the articles and the books will come to you with no conditions. No one's chasing you. All you got to do is get them and read them selectively to get the information you deserve. If, on the other hand, you've got a complex problem that doesn't seem to be being resolved, and I think you'll see that when you read the first article I posted there, the link that's there. When you read that article, I think you'll understand the nature of the complexity of this problem. They're overactivated, and what we're interested in is the activation. And there's another test we can do, it's called the K562 test. And there's other tests we can do in the blood, Treg cells, T regulatory cells. We can look at those and KIRs, but they give us more academic information. They don't allow us to improve or expand on how we treat. And I don't believe in doing tests that are not going to influence treatment. So for me to tell if you've got the problem immunologically, you do antiphospholipid antibodies. All 21 of these antiphospholipid antibodies would be measured at Reprosource or equivalent laboratories. The other labs do 3 or 4 different ones and they're not good enough. Second, do you have activated natural killer cells by the K562 test? Do you have the type 1 cytokine activation? Is that a problem? Do you have antiphospholipid antibodies? When we look at all your lymphocytes, do you have evidence of T cell activation with HLA-DR being increased? So the things we can do to see where the problem lies, hone in on the problem, fix it and eliminate it. I have a lady that came to me for another autoimmune condition like endometriosis, which causes natural killer cell activation. It's autoimmune hypothyroidism, where women have got antibodies to their thyroid. I was in Australia giving a lecture, and it was packed, and a lady came up to me. She was a doctor. She was 42 years of age, a lung specialist, and she came to me and she said, "Doctor, can you help me?" I said, "What is it?" She said, "I've done 24 failed IVFs. And now I'm at a stage at 42 where my AMH is 0.2, so I'm premenopausal. I don't have many eggs left. I want to have a baby. Can you help me?" Knowing that 50% of women who've got thyroid antibodies will have activated natural killer cells with increased type 1 cytokine expression, I took her blood, took it with me to America, did the test. She was positive. She and her husband came to the United States. We did IVF in her first cycle. I could only get 3 eggs out of her. Only one was PGTA and all, and I already explained to you, Dr. Tortoriello and I introduced PGTA testing into the field some 20 years ago, and she was one that was good, put that in her uterus, and I'm the godfather of her child. So it's really important to understand. You've got to deep dive into the variables that can affect outcome. You can't just go duck hunting, thinking you're going to have a roast duck dinner and just aim where you hear quacking. You've got to take aim. You've got to shoot at a target. So we've got to know what all the factors are, lay them out, evaluate them, and then target the problem, and then we'll be successful. Please believe me, go to the website, to the bio, and get the 3 articles I wrote. One of them I finished literally 10 minutes before this webinar was started. It's the best article I've written on endometriosis, and it gives you a clear breakdown of how you need to look at it. Read that, and then after that, it's the first one, after that read the other 2, and then go to the book. The 2 books that I give you free of charge, without condition, downloadable ebooks. Read those. There isn't a single reason why everybody present should not get access to this reading material without any commitment required. For those of you that are interested in talking to me, so I can help you through this, believe me, it takes experience and seasoning to find your way through this quagmire that endometriosis creates. It's not just a diagnosis, you treat it this way, it solves the problem. It is a complex issue. Each person with endometriosis is effectively different. If you want to talk to me, I urge you, click on the link that gives you access to a questionnaire that's 4 minutes long. Fill it in, forget about it. It'll come to us. We will then reach out to you and set you up with a consultation online with me, which can be done online, and you're not committed to doing it. You're just getting a position for yourself, and if you don't make application, it is first come, first serve. I'm afraid I might not get to you. So try to get to it as quickly as possible if you're interested, and arrange for us to talk. You can back out, there's no pressure on you, but at least you've got your foot in the door.
Great information right there. We're going to answer, hi everybody on TikTok. They said, what is the difference between polycystic ovaries and multifollicular ovaries?
Well, polycystic ovaries, now it's called PMOR, no longer called PCOS. It's a complex metabolic condition. The name has been changed. I'm going to be doing a webinar on PMOR in the next few weeks. If you have an interest, keep an eye open, and when you see it comes up, please join us and let the world know about it. There are many people who want to hear the information that we can provide. But the most important thing is to know that follicular cysts are the same as the small little cysts under the capsule of the ovary, which gives it the name in the past, polycystic ovaries. There's more to it than cysts in the ovaries, which is why the name has changed. But it's a complex situation. I'll be happy to talk to you about it. If you get the books, I've got a whole chapter on polycystic ovaries. In the book, it's still called PCOS. So go to the book and read it. Download the book, get the copy for yourself and read it.
Great answer. Katie, she says, why am I in so much pain after multiple endo surgeries? And so let me open it up. multiple endosurgeries and the coil.
Well, you've got a coil in there, I don't know why. Unless you're obviously not trying to get pregnant, you're more concerned with the pain issue. You are a candidate for using GnRH antagonist long-acting injections monthly to suppress the lesions and make them shrink and reduce the pain. And then you've got to get onto a regime of painkillers. There are various types of painkillers you can use. Using a birth control pill is not going to help you. What you've got to do is you've got to deal with shrinking the endometriosis. And if your pain becomes a major issue, there's a surgical procedure that can be done. I've done many of them in the past, and it's called a presacral neurectomy. We go in through a laparoscope, and just above the tailbone, there's a nerve that crosses over the pelvis into the pelvis that feeds all of the organs. What we do is we go in and we transect that nerve. It cuts off the pain fibers to the pelvis, removes the pain, doesn't cure the condition. It's still ongoing and you have to keep an eye on it to make sure it's not getting worse, but it can reduce the pain substantively. Presacral neurectomy. Discuss that with your reproductive surgeon.
I just want to say thank you to everyone who's filling out the form right now. I see more push notifications coming through. Thank you guys so much. Dr. Sher will reach out to you as soon as possible. You guys have your foot in the door now, and you'll have a consultation shortly, or talk to him one-on-one. There's also free articles in there. Please make sure everybody who's in the chat right now, go get your free articles, free ebooks, all of it specifically about today's topic and just other IVF knowledge that you can't get anywhere else. We're going to answer H. Dults on TikTok here. They've been commenting for a second now. They said, oil or foam for a fallopian tube check with potential... Open the message here. With potentially blocked from IVF, last resort.
I'm going to tell you something you're not going to want to hear. Rarely does endometriosis block the tubes. And there's a reason. It occurs outside the uterus and the tubes. It grows inward. On the other hand, when you get pelvic infection, STDs, gonorrhea, chlamydia, it travels up through the inside of the tube and destroys it by inflammation, blocks it, and it can fill up with fluid. Endometriosis rarely does it. It doesn't mean it can't. If it damages and blocks the ends of the tubes, the fimbria, the finger-like projections that then fold in one another and fuse, the tube can be blocked. But rarely will it ever cause fluid in the tube. It'll block the tube, and that can be bypassed through IVF. Because the tube's blocked doesn't mean you need surgery at the tube. It's only if it's filled with fluid. So if you've got a blocked tube and you've got stage 4 endometriosis and there's fluid in it, one of the possibilities you've got to think of is that you might also have had inflammation in the tube, and that changes things. And in order to differentiate between the two, we're going to need to talk. So you may be one of those people that may benefit from filling in that questionnaire on the bio so that you and I can have an online consultation. You're not committed, you're not pressurized, but at least if your name is down and you make the request, we have to get to you if you get there while we're still on the line here. For those of you who want to talk to me, I urge you, fill in that questionnaire and do it now.
Perfect. I see a lot of push notifications coming through. Thank you guys so much. If you're filling out the form or getting the books, whatever you're doing over there, thank you so much. We really appreciate that. We're going to answer user 23 here. Also, thank you guys for the gifts. I see a lot of gifts coming through. It means a lot to us. We don't do this for gifts or anything on TikTok. We just love giving out information and helping you guys. But thank you so much for the gifts. We really appreciate that. User 23, we're going to answer your comment here. It didn't let me pin them. Alright, I gotta go find it. 1 second. It says, 3 miscarriages, did hysteroscopy and found septum and polyp. How successful can pregnancy be now?
The polyp is probably more important than the septum, unless the septum descends more than halfway down the uterus. Having a septum that's partial, a dimple in the uterus, is not a cause of early miscarriages. It causes late miscarriages or premature labor, and it may be an indication for the baby not being able to spin around when it gets to the time for delivery, so that it's not head down and the doctor has to do a cesarean delivery. But it doesn't commonly cause early miscarriages. The embryo has a way of finding its way around the uterus to the best part to implant, and it's not going to try to implant on the septum usually. So for that reason, The fact that you have got a septum in there is interesting, but I don't think that is the most likely explanation. The polyp, that's a different story. That can irritate the lining, cause these immune cells to rush to the uterine lining and expel the pregnancy. I don't know how many of you know this, but as a matter of interest, how many of you realize that when you put a coil in the uterus, an IUD, to contracept, you're not preventing pregnancy? What you're doing is irritating the lining by putting in a foreign body into the uterus, and that attracts all these immune cells to the uterine lining, and when the embryo comes along to the uterus to try to attach, it gets destroyed and doesn't attach. That is how an IUD works. It doesn't work by preventing an egg from fertilizing. It prevents the embryo from attaching by destroying it. And for that reason, if you've got a polyp, it's your own built-in IUD, your own built-in foreign body, which attracts these same immune cells to the uterus, attacks the embryo, and either prevents it attaching or prevents it attaching properly, and you miscarry.
All right, we're going to answer Molly on TikTok. Thank you guys for filling out the form. I see more notifications coming through. Thank you for getting those books. I have to go back up here to find their message again. I'm so sorry. Not everybody has pins accessible. Okay, Molly said, I had ultrasound this week, no endo, laparoscopy, diagnosis last year, and still pelvic thoracic pain. Any suggestions?
If it's for the pain, we've got to find out why you're having the pain. You say no endometriosis, and I've just pointed out earlier, you could have endometriosis without even seeing it or knowing it. You could be so early. You could come back 4 years later and do another laparoscopy and find visible endometriosis. So it doesn't mean that because nothing is seen that it isn't there. But if you're having pain, there should be some tangible reason for it. It's impossible for me sitting here just hearing what you've got to say to give you a reason. I would need to talk with you. And for you and many others like you who want to get some information, I urge you to consider you're not under pressure. There is no solicitation, none. My job is to inspire and educate. Your job is to decide what you need. And if I can give you information that helps you get to the bottom of your problem, I need to talk to you. And that means get yourself lined up. You may not do it, you can change your mind. You're not obligated, but at least you're in line. And so consider filling in that questionnaire. Getting it to Patty. By just filling it in, we'll get back to you and set up a time to talk to you if you're interested. And if you change your mind, so be it.